Moving on to our next session, I would like to invite Dr. Sanu P Moideen on stage as a speaker of the session. How I do it. Pediatric Adenotonsillectomy. I also request Dr. Febin James, Consultant ENT Specialist at Excell Hospital in Kozhikode, to kindly chair the session.
Dr. Sanu P Moideen is a highly respected ENT, head and neck oncosurgeon with exceptional academic credentials and a focus on patient care. After his post-graduation, he received his fellowship training in head and neck oncosurgery from the Regional Cancer Center in Trivandrum, fellowship in endoscopic skull base and sinus surgery from JK University, Japan, and fellowship in snoring and sleep apnea surgery from AIG Hospitals, Hyderabad under Dr. Srinivas. He also received specialty training in pediatric ENT from Christian Medical College, Vellore, and from Texas Children's Hospital, US. He received the International Visiting Scholarship by the American Academy of Otolaryngology and Head and Neck Surgery in 2018. Over to you, sir.
Good morning. My topic today's our sessions are mainly for surgical how I do it sessions. So my topic is based on just the most common surgeries we are doing in the pediatric practice, which is adenotonsillectomy. So for the first line management, all the literature says the first line management of pediatric OSA is adenotonsillectomy, and it has shown that it has given improvement in symptoms and sequelae in most cases, improvement in polysomnographic findings, improves the overall quality of life of the kids. And when checking with the comorbid conditions of the kid, like allergy, asthma, all those things, pediatric adenotonsillectomy also has shown that it improves the asthma control, our improvement of the long-term control, because all these, the newer studies are showing that obstructive sleep apnea is not because of obstruction alone, it's because of the inflammation in the upper airway. So when the inflammation in the upper airway is controlled with the leukotriene antagonist, steroid nasal sprays, etc., the kid is getting better. That's why the thing that when you give an intranasal corticosteroids, the adenoids are going to be still there. It's not going to vanish, but the kids are getting symptomatically improvement because the inflammation is controlled with the steroids. So same way, if you treat with the leukotriene antagonist, etc., the comorbid conditions can be reduced, and with an adenotonsillectomy also has shown that it improves the comorbid conditions like allergy and asthma. And this is the famous landmark study, the CHAT trial. It has shown that compared to wakeful watching, early adenotonsillectomy has shown to improve the behavioral outcomes, quality of life, increases the weight gain, and normalization of PSG findings in kids. There are currently only 3 randomized controlled trials on adenotonsillectomy versus wakeful watching, and those are the 3 studies which all has shown that early adenotonsillectomy gives a significant improvement. And the last study is that adenotonsillectomy reduces the healthcare utilization of kids. So the American Academy of Otolaryngology Head and Neck Society came up with the guidelines that all cases with a moderate to severe OSA in pediatric population, the first line of management is adenotonsillectomy. But the Academy gives that for mild OSA, the wakeful watching is the advised. But the problem with wakeful watching is that we have already seen that if you take the kids for early surgery, the quality of life is much better, and the comorbidities like changes in the facial profile, development of an adenoid facies, etc., can be avoided if you consider an early surgery. Even the American Academy of the Pediatrics also recommends adenotonsillectomy for the kids with very big adenoids and tonsils. But the problem is again that, like I said earlier, obstructive sleep apnea is due to inflammation. The size of the adenoids or the tonsil doesn't matter. It's the upper airway inflammatory load. So sometimes you may see that it's a grade 1 adenoids or a grade 2 adenoids, and you may be hesitant to do the surgery. But if the kid is symptomatic, if you reduce the inflammatory load with a surgery or something, and then the kid will become better. So what are the challenges of adenotonsillectomy? Why you are most hesitant to do adenotonsillectomy is mainly because of one is the post-op pain, usually may last for about 1 week. Second is that unplanned revisit. It can be due to dehydration, reduced food intake, pain and bleeding. With all the studies have shown that post-op pain chance is up to 4 to 6% in a routine adenotonsillectomy. And the second thing is, when we do adenotonsillectomy, most of these days the indications for adenotonsillectomy is mainly obstructive sleep apnea. It can lead to post-op. In kids with obstructive sleep apnea, it can lead to respiratory adverse effects including pulmonary edema, hemorrhage and death. So these are the risks why we restrict ourselves from doing an adenotonsillectomy. But to overcome this, we have various surgical steps, innovations in surgical methods, instruments, all those things. We have ligashers, clips, radio frequencies, debriders, all those things. And when the real challenge to me, when if someone asks what is the change in the practice of adenotonsillectomy in the pediatric population, the real game changer is the introduction of coblation and the intracapsular tonsillectomy method. So what is, I will explain detail. What is coblation? Coblation is a controlled ablation of the tissues. I will go a little faster so that I can demonstrate the surgeries. It's a radio frequency ablation of the tissues, and compared to the conventional coblation versus electrocautery, the temperature is shown that coblation is associated with less temperature. Thermal penetration is very less, so the collateral damage is very less in coblation. Target tissue effects, the gentle removal of the tissue is possible with coblation, and effects on surrounding tissue is also very less since the diameter is only 100 to 200 micrometer. So it just removes the targeted tissues. The second thing is the introduction of the intracapsular tonsillectomy. Intracapsular tonsillectomy or partial tonsillectomy, also called as tonsillotomy. It was introduced by Kotai in 2009. He used a debrider for doing a partial tonsillectomy procedure, and it was found to be safe, and this is how we are doing it. This is the conventional extracapsular method. Since the videos cannot be forwarded in the other format, I will change. Okay, so we have tried the tonsil, but compared to the usual method, what is the difference when you use a coblation is, usually we are going between the plane of the anterior pillar and the tonsil, but here we are going little laterally, and a part of the pillar is a little taken for the maneuver of the instrument. So almost an avascular plane can be obtained with a coblation. So without shedding a single drop of blood, we can do the surgery. So that's one really advantage in coblation, because these young kids, they may have failure to thrive, and the weight may be very less. So the blood volume will be less. So doing a safe surgery is possible with the introduction of coblation techniques. And second is the intracapsular method, where we are doing the tonsillectomy in a way where we are going from medial to lateral and debulking the tonsil, because like I said, most of the indications are for obstructive pathologies where we are reducing the size of the tonsil and associated inflammatory load. The advantage of intracapsular tonsillectomy is that since we are not, the histopathological studies of the tonsils have shown that when you breach the capsule, when you go beyond towards the cross the capsule, the size of the blood vessels are very large. So beyond the capsule, the size is large, and after the capsule, it's very thin blood vessels. So the chance of bleeding is less. Second thing is, you are not creating a big wound. In normal extracapsular tonsillectomy, you are creating a big wound, exposing the muscles in the tonsillar bed. Sometimes even the glossopharyngeal nerve may be exposed. So that's a problem when you do an extracapsular tonsillectomy. But in intracapsular tonsillectomy, you are leaving behind a small, maybe a 99% of the tonsil is removed, but a bit of tonsil tissue, membrane-like tonsil is left behind. The advantage is that this tissue, it acts as a slough or a biological dressing. So the chances of rebleed, etc. are less with an intracapsular tonsillectomy. Again, the surgery is safe without any way. Since I told, like when you cross the capsule, the size of the blood vessels are very narrow. The bleeding will be very less. You can easily coagulate at the same time. But the limitation is that you need some kind of magnification with either microscope or loupe. You need to identify the capsule of the tonsil, the color change. if any bleeding comes, you can bipolar it immediately, coagulate, okay. So I have gone beyond that, just broken the capsule a bit. Even if that happens, it's no okay, because it's just like you are doing an extracapsular. Nothing going to happen, you just coagulate it. So this is the capsule. You can appreciate the color change here. Here. See the color change in this part. So that's the capsule. So you are leaving behind the capsule intact. So coming to the comparison of extracapsular versus intracapsular technique, extracapsular is the most common method we followed worldwide. Intracapsular is really a newer method, and it involves the removal of the tonsil along with the entire capsule, but in an intracapsular tonsillectomy, a part of the tonsil tissue is left behind. Another concern is the chances of regrowth, but again the question is whether this regrowth is symptomatic. So even if the kid comes back with a small amount of tonsils or adenoids residual, as long as it's not symptomatic, we can have a waitful watch for the problem. And the studies have shown that intracapsular tonsillectomy is safe, and it reduces the post-tonsillectomy hemorrhages, reduces the post-operative complications, less post-operative pain, perioperative blood loss is also less, and earlier time to return to normal activities. So this is our own study about the comparison of extracapsular versus intracapsular tonsillectomy. Average time for one-side tonsillectomy was 7.3 minutes in an extracapsular and 9.2. It takes little time extra. Immediate post-op pain score was 6.2 compared with the 4.8. Time to become pain-free was for 4.4 days, and 2 days earlier, kids returned to normal life. Duration of voluntary analgesic. After doing an intracapsular tonsillectomy, we never send them on mandatory paracetamol or anything. We are just sending one analgesic, paracetamol, 15 milligram per kilogram, and that too we'll inform the mother, give the medicine only if the child says pain is there. Okay, otherwise you don't need to take paracetamol. So that's why I put as voluntary analgesics up to 5th day when extracapsular, and by 3rd day most of the kids stops taking paracetamol in intracapsular. Post-op day 1 edema, uvula edema less frequent with intracapsular, and primary hemorrhage, thank God we don't had any hemorrhages till now, but secondary hemorrhage we had one case for intracapsular tonsillectomy, but it was managed conservatively. And tonsillar regrowth, we have seen regrowth in 4 kids, but it's asymptomatic. And so as of now, what's the limitations of doing intracapsular tonsillectomy? The problem is that American Academy of Otolaryngology doesn't endorse intracapsular tonsillectomy. The problem is that there are no long-term data. So after the guidelines came in 2009, studies have came up with the long-term data, with not long-term, more than 1 year. So it has shown that better patient results and better quality of life. And one concern is that what's the role in chronic tonsillitis? Still, we don't have long-term data, but as of now, it's not recommended in long-term chronic tonsillitis, PFAPA syndromes, etc. Usually, it's recommended for OSA. A randomized controlled trial is going on. Hopefully, the results will be out by 2022. 27. So we may be able to have a long-term data by then. Till then, when the long-term data comes, the ideal candidate is a kid with OSA, obstructive sleep apnea. And the take-home message is adenotonsillectomy can be done safely now with less chances of post-op bleeding, morbidities, etc. And the intracapsular tonsillectomy is a good technique associated with less pain, less morbidity, and early recovery. Thank you. I was little fast so that we could make our invited faculties need more time, so that's why. Okay, sorry.
Thank you, sir. We'll now have a minute for any questions.
Sanu, in your clinical practice, when you're doing intracapsular tonsillectomy, what is the chance of recurrence of tonsil later on, and how do you convince a patient about this thing?
before taking the patient for the surgery itself, I'll tell, I'm going to do a partial tonsillectomy. I'm not going to remove the entire tonsil. I'm just going to do a partial tonsillectomy. A bit of the tonsil tissue may be remaining because it's for the safety of your kid. There are two ways of doing it, complete tonsillectomy, partial tonsillectomy. I'm going to do a partial tonsillectomy only because at this age, if it's my own kid, I will be doing an intracapsular only. So that's one answer. So the parent, only after they accept, I will go for an intracapsular tonsillectomy. Second thing, even if the tonsil regrowth, it's not going to be it may not be a troublesome for the kid. It may be a grade 1 tonsil, asymptomatic, you can leave it.
What about the chance with bleeding when you leave tonsil tissues?
Nothing, because same time we are ablating also. We are coagulating all the blood vessels. The device is very good. And like I said, the blood vessel, size of the blood vessel, that's a histopathological study. The size of the blood vessels is very narrow once you cross the capsule. So as long as the larger blood vessels are not exposed, chance of bleeding is less. Then it forms a biological covering over the heel wound.
Thank you.
Thank you, sir. Thank you, Sanu, sir. That was a very informative session. I would like to request Dr. Nikhil Sridharan, Assistant Professor, Government Medical College, Kozhikode, to kindly felicitate the chairperson.